Welcome to today's paper reading. Today's paper is titled, A Survey of Large Language Models in Medicine, Progress, Application, and Challenge. This paper was published on AR14 by Hongjian Zhou and colleagues from the University of Oxford. The development of medical large language models, LLMs, involves models ranging from 110 million to 520 billion parameters. These models are primarily developed through pre-training, fine-tuning, and prompting methods, utilizing large-scale medical corpora from diverse sources. Most existing works evaluate their performance on exam-style question-and-answer (QA) tasks, where a reasonable combination of different fine-tuning and prompting methods enables LLMs to achieve results comparable to or even better than experts. However, LLMs' poor performance in non-QA tasks without preset options, which are common in clinical practice, indicates a considerable need for advancement before LLMs can be integrated into the actual clinical decision-making process. Adapting medical LLMs to various clinical applications has received increasing research interest. However, large-scale clinical trials specifically targeting existing medical LLMs are currently missing. Addressing the challenges and future directions, regarding mitigating hallucinations, establishing robust data, benchmarks, metrics, and addressing ethical, safety, and regulatory concerns through interdisciplinary collaborations, is important to accelerate the integration of LLMs into the clinic. Figure 1 provides an overview of the practical guides for developing and deploying medical large language models, LLMs. These models, which range from 110 million to 520 billion parameters, are primarily developed through pre-training, fine-tuning, and prompting methods, utilizing large-scale medical corpora sourced from various domains. The figure highlights the importance of these methods in creating effective medical LLMs, which are essential for enhancing clinical diagnostics and medical education. Additionally, it underscores the need for comprehensive evaluation frameworks to ensure the responsible and effective utilization of these models in healthcare. Medical large language models, LLMs, represent an adaptation of general LLMs to the medicine domain, aiming to improve patient care. Despite promising results, key issues in their development and application need addressing. Many models primarily focus on medical dialogue and question-answering tasks, often overlooking their practical utility in clinical practice. There is a lack of practical guidelines for developing these models and a need for comprehensive evaluation frameworks. These research gaps motivate a review that covers the development of LLMs, their applications in medicine, and the challenges they face. Table 1 provides a comprehensive summary of existing general large language models, categorizing them into three main types based on their architecture: encoder-only, decoder-only, and encoder-decoder. Each category includes notable models such as BERT for encoder-only, the GPT series for decoder-only, and FLAN T5 for encoder-decoder. The table details the number of parameters for each model, ranging from 110 million to 130 billion, and the datasets used for their training, which include massive corpora like Common Crawl, Wiki, and books. This summary serves as a valuable resource for understanding the landscape of general large language models and their respective capabilities. The development of medical large language models, LLMs, involves three primary methods: pre-training, fine-tuning, and prompting. Pre-training typically involves training an LLM on a large corpus of medical texts, including both structured and unstructured text, to learn rich medical knowledge. Fine-tuning reduces computational costs compared to pre-training by adapting general LLMs to the medical domain using methods like supervised fine-tuning, SFT, instruction fine-tuning, IFT, and parameter-efficient fine-tuning, PFT. Prompting efficiently aligns general LLMs to the medical domain without training any model parameters, using methods such as in-context learning, ICL, chain of thought, COT, prompting, and prompt tuning. Figure 2 provides a summary of medical domain large language models, LLMs, based on their model architectures. The figure categorizes these models according to the methods used in their development: pre-training, fine-tuning, and prompting. It highlights the varying number of parameters, ranging from 110 million to 70 billion, which indicates the scale of these models. Additionally, it notes the diverse data sources utilized for training, including PubMed, Mimic3, and electronic health records, EHRs. This figure is crucial for understanding the landscape of medical LLMs and their development strategies. Figure 3 presents a comprehensive comparison of the performance metrics for GPT 3.5 Turbo, GPT-4, state-of-the-art task-specific lightweight models, and human experts across 7 medical tasks spanning 11 datasets. The data showcased in this figure is sourced from published and peer-reviewed literature, ensuring the reliability and validity of the comparisons. Notably, GPT-4 demonstrates strong performance, particularly in the QA task, where it is shown to be comparable to human experts. This figure underscores the advancements in medical LLMs and their capabilities in handling complex medical tasks. For detailed data and further analysis, please refer to the supplementary material provided. Table 2 provides a comprehensive overview of the current landscape of medical domain large language models, LLMs. The table categorizes these models based on their development methods, which include pre-training, fine-tuning, and prompting. Pre-training typically involves training an LLM on a large corpus of medical text to learn rich medical knowledge. Fine-tuning adapts general LLMs to the medical domain using supervised, instruction, or parameter-efficient fine-tuning methods. Prompting efficiently aligns general LLMs to the medical domain without training model parameters. The table also details the number of parameters for each model, which ranges from 110 million to 70 billion, reflecting the varying scales of these models. Additionally, it lists the scale of pre-training and fine-tuning data, indicating the volume of tokens and notes used in training. The data sources for these models are diverse, including PubMed, Mimic3, and other specialized medical corpora. This information is crucial for understanding the capabilities and limitations of existing medical LLMs, guiding the selection and development of models for specific medical applications. In the realm of medical machine learning, 2 primary types of tasks are commonly discussed: discriminative and generative tasks. Discriminative tasks, such as question answering and entity extraction, are designed to categorize or differentiate data into specific classes. These tasks are crucial for clinical decision support, helping clinicians make more efficient and accurate diagnoses. On the other hand, generative tasks, including text summarization and text generation, focus on creating new, fluent text based on given inputs. These tasks aim to improve the readability and accessibility of medical information, making it easier for both clinicians and patients to understand complex medical texts. Performance comparisons show that while large language models, LLMs, excel in question-answering tasks, they still lag behind in non-QA tasks. This indicates a need for broader evaluation and improvement in LLM capabilities before they can be fully integrated into clinical practice. Figure 4 illustrates the progression of medical large language models, LLMs, over time, categorized by their development types. The performance of these models is measured through their scores on the United States Medical Licensing Examination, USMLE, from the MedQA dataset. In the figure, solid lines represent open-source models, while dashed lines represent closed-source models. This visualization helps in understanding how different types of model development have influenced the performance of medical LLMs over time. Figure 5 provides an integrated overview of the potential applications of large language models, LLMs, in the field of medicine. These applications include medical decision-making, clinical coding, and clinical report generation. LLMs are being integrated into clinical decision support systems to provide evidence-based recommendations and references. Additionally, tools based on LLMs are being developed to assist in clinical trial recruitment by analyzing electronic health records to identify eligible participants. In the field of medical education, LLMs are being considered as tools to enhance learning experiences by providing personalized content, answering questions, and offering interactive educational materials. This figure highlights the diverse ways in which LLMs are being utilized to improve various aspects of medical practice and education. In the realm of medical decision-making, LLMs assist in tasks such as diagnosis, prognosis, and treatment planning by processing vast amounts of medical data. For clinical coding, LLMs automate the assignment of ICD, medication, and procedure codes, enhancing both accuracy and efficiency. In clinical report generation, LLMs, particularly those integrated with vision language models, facilitate the creation of radiology reports and discharge summaries, improving the quality and speed of documentation. Table 3 provides a comprehensive summary of existing medical large language models, LLMs, tailored to various clinical applications. It outlines the architecture, model development, number of parameters, data scale for pre-training, PT, and fine-tuning, FT, and data sources used for these models. The table also includes evaluation metrics such as task performance scores, which help in understanding how these models are currently being assessed. This information serves as a guideline for selecting, building, and evaluating medical LLMs for different clinical applications. Key points include the use of in-context learning, ICL, fine-tuning, FT, and pre-training, PT, in model development, with parameters ranging from millions to billions. Evaluation metrics highlight the model's performance in tasks like diagnosis summarization and differential diagnosis. In the adoption of large language models, LLMs, for medical applications, several challenges arise. One major issue is hallucination, where LLMs produce inaccurate or not factual information. This can be intrinsic, contradicting factual data, or extrinsic, where the output cannot be verified. Such inaccuracies can lead to medical misinformation, necessitating corrections during both training and generation phases. Another challenge is the lack of appropriate evaluation benchmarks and metrics tailored for the medical domain. Current benchmarks often fail to assess LLM-specific metrics like trustworthiness and explainability. There is a pressing need for medical-specific benchmarks to better evaluate LLMs. Additionally, the medical domain faces data limitations. The datasets available are relatively small, raising ethical and privacy concerns. Techniques like synthetic data generation are being explored, but they come with their own set of challenges, such as potential model forgetting. Further challenges include the adaptation of new knowledge into LLMs. Updating LLMs with new medical information is costly and inefficient, and ensuring that old knowledge is appropriately forgotten is difficult. Timeliness of updates is another issue, as medical knowledge needs to be current. Behavior alignment is also critical. Ensuring that LLMs align with the objectives of medical tasks is challenging due to discrepancies between general human behavior and medical professionals. Misalignment can lead to ethical concerns and harm. Lastly, there are significant ethical and safety concerns when using LLMs in the medical domain. These include ethical use in biomedical research, accountability in clinical practice, and risks of personal data leakage, which pose substantial vulnerabilities. Figure 6 outlines the future directions of large language models, LLMs, in clinical medicine, emphasizing both their development and deployment. The figure highlights the need for comprehensive benchmarks to evaluate LLMs' performance in clinical applications, moving beyond traditional accuracy metrics to include clinical skills, ethical considerations, and real-world adaptability. It also underscores the potential of multimodal LLMs, MLMs, to integrate time series, visual, and audio data, enhancing diagnostic capabilities and patient monitoring. Additionally, the figure points to the importance of LLMs in underrepresented medical specialties, such as rehabilitation therapy and sports medicine, where they can disseminate accurate knowledge and aid in personalized program creation, particularly in resource-constrained environments. These advancements aim to improve LLMs' utility and reliability in healthcare, ensuring they meet the diverse and evolving needs of clinical practice. The future of medical LLMs involves several key directions. Firstly, the development of new benchmarks is crucial to better evaluate LLMs in clinical settings. These benchmarks should be comprehensive, evaluating clinical skills beyond mere accuracy, and consider ethical and fairness aspects. Secondly, multimodal LLMs, which integrate vision, audio, and language, offer promising avenues for medical applications, particularly in processing time series data like ECGs. Lastly, LLM-based medical agents can specialize in various medical roles, enhancing collaboration and decision-making processes in healthcare. These agents can continuously learn and adapt through feedback loops, improving their performance over time. Thank you for watching.